Assalamu alaikum wa rahmatullah. Good evening, everyone. Thanks for joining us today for the first Young Leader Forum Symposium for the year 2024. Today, the theme for our webinar is cardiometabolic disorders, and we have 3 talks with eminent speakers. But just before starting, we have some housekeeping announcement. First, this webinar is also live streamed on YouTube channel, so you can also view it there if you could not log in here. This activity is accredited 2 hours by DHA. And please through the presentation, put your question in Q&A section, and first specify the speaker for whom you want to direct your question. This recording will be later available in YouTube channel as well as on-demand webinars on the Society website, so you can view it later anytime. We extremely thank Servier for their unrestricted support for this activity that has been going through for the last few years. So without further delay, we will start with the first talk, which is titled, When Should We Treat Mild to Moderate Hypertriglyceridemia? And our speaker is Dr. Nada bin Hrez. Dr. Nada is consultant endocrinologist at Tawam Hospital and assistant professor at UAE University, College of Medicine and Health Science. She completed her endocrine fellowship at University of Ottawa, and she is a certified American board in lipidology. Thanks, Dr. Nada, for joining us, and the virtual floor is yours, so please share your presentation.
Thank you very much, Dr. Raya, for the nice introduction. So this is my talk for today. When should we start mild to moderate hyperglycemia treatments? Okay, I don't have anything to disclose. I will start with the case who I saw in the clinic. She's a 37 years old patient with hypertriglyceridemia. She referred for a lipid clinic for assessments. So nothing significant in her past history. She's on OCP. She's gravida 3, para 3, an employee, have sedentary lifestyle. She depends on carb mainly for her diet. There is no any ASCVD or diabetes in her family history. Or her examination is unremarkable other than overweight. Her BMI is 28. So her lab work showed that total cholesterol was 5.17 millimole. Triglyceride is 5.47. HDL cholesterol is 0.9, non-HDL cholesterol 4.2, ApoB is 1 gram per liter, glucose is 4.4, HbA1c is 5.4%, other transaminase, TSH, light, urinalysis, all is within normal. Her triglyceride have more than 2 or 3 reading with the same, like ranging between 5.4 to 6. So if you saw like this case, first, I wonder how many of you are used to order ApoB, and we will talk about why we ordering ApoB in patient like this is important. But just to let you know that this level is normal, and usually the red flag is 1.2, where it's carrying red flag features. So what should be done next for the patient? After considering lifestyle modification and removing risk factor, did you start omega-3 fatty acid, start fibrate, start icosapent, estimate ASCVD risk, or optimize LDL treatments? So please keep mental note for your answer, and then we will come back at the end to see. So first of all, when we would like to think about, maybe all of us would think, why does she have hypertriglyceridemia? And then will harm her? And how? And should I treat this or no? So to answer this is my objective here. I think we need to review triglyceride lipoprotein physiology, consider impact of hypertriglyceridemia on health and disease, and to update the guidelines for treatments of hypertriglyceridemia. Did we need to treat the triglyceride or the lipoprotein. So for the people who want to lift early, so just this is very important here. I summarize the point. Triglyceride associated with ASCVD and acute pancreatitis. Hypertriglyceridemia is the consequence of combined impact from genes and environment, rarely monogenic. Treatments, it's mainly on 2 points. Either you want to protect acute pancreatitis risk or you want to protect ASCVD. So for acute pancreatitis, lifestyle modification and TG lowering treatments. ACVD risk, usually risk factor modification, statin ApoB based lowering regime, and EPA treatments. So first of all, hyperlipidemia can be classified in many ways. Lipid, as first when you see, you will either say the patient have high cholesterol, like hypercholesterolemia, or you will say this patient have high triglyceride, or both of them combined hyperlipidemia. But do you think is really that's enough? If you really want to understand what's going on, you must understand which lipoprotein is abnormal. Does carrying the carrying the lipid, because different implication for prognosis, it will give you different implications for treatments and different implication for response to therapy. So knowing whatever somebody have or has high level of LDL versus VLDL versus chylomicron or combination, is it really matter? Yes. And that's why we need to go over it and see. And then also you can classify the patient based on clinical syndrome like familial combined hyperlipidemia, or you have familial hypertriglyceridemia, or you have FH patient, familial hypercholesterolemia. And then you have with emerging of molecular time, if we have access to genetic testing, and it is good to think of what gene is abnormal. There is a complex interaction between the genotype and the environment. There is chance always you can predict the outcome when you know which gene is the causative for this syndrome. So that's how I usually think in the clinic. Usually, first of all, and that's how I talk with the residents and all who've been in my clinic, like, please think about the lipoprotein first, not the number. So then from lipoprotein, you can expect the biochemical diagnosis, and you can even think about what the molecular diagnosis could be. So for the guidelines, like update guidelines for the serum triglyceride concentrations, here we have on the top the European guidelines, which usually consider normal as less than 1.7 millimole, and moderate hypertriglyceridemia at between 1.7 to 9.9, and severe, which it is above 10 millimole. And down we can see the Endocrine Society Clinical Practice Guidelines. They classify it more in detail, like normal, and then mild and moderate hypertriglyceridemia and severe hypertriglyceridemia. And usually, which I like to follow, is the middle one, which it is the AH, the American Clinical Cardiology Guidelines, which show that the normal is 2 and below millimole, and then mild to moderate is 2 to 5.6, and severe it's 5.7 and above. Where that is my talk today, it's mild to moderate, so I will not talk about severe hypertriglyceridemia. Then for etiology, we know that there is a lot of acquired cause, environmental cause. It can be range from diet, medication, metabolic condition, medical condition, and there is an inherited syndromic causes like monogenic or polygenic. Here, I like this diagram which show us to understand more about the etiology and what the effect of genetic and environmental factors on patient hypertriglyceridemia. So the yellow circle, it's considered the genetic factors, and the blue one is the environmental factor. So we can look to the messenger, which represent the phenotype, and the size of the messenger represent the prevalence of triglyceridemia. of the phenotype. If you think about the small jar, which represent the rare, infrequent cause of severe hypertriglyceridemia phenotype, has been caused by monogenic disorder, severe monogenic circle disorder. You can see here, like, you can detect that the effect of the environmental factor on this patient is very low or very little in compared to the effect of genetic factor. So the yellow circle is the gene. So a single gene mutation that have a major impact, less impact by environmental factor. And in the another way, when you look here, and you can see the effect in severe hypertriglyceridemia caused by multiple gene. You can see here many yellow circle. It's polygenic causes of the phenotypic polygenic environmental impact is much greater on those populations. And that's why here it makes sense like to consider lifestyle modifications. You give a lot of advice about weight loss, diet, but in this type of patients, sometimes I'm being okay with them, even if they say for exercise, we know it's 5 to 7% only, or maybe less, but it's mainly the genetic, which it is affect his hypertriglyceridemia. So, and we can see here that there is many loci, like more than 45 loci associated with variations in the plasma triglyceride concentration. So there is a lot of diagnosis for those patients. And it's a very famous word. Usually you will see it in many publications mention about most cases of hypertriglyceridemia are felt to be polygenic, with strong influence by environmental factors. So here, again, to understand more the lipoprotein, sometimes we can estimate what the cause of this hypertriglyceridemia by knowing the ratio of triglyceride to total cholesterol. For example, in the chylomicron, we can see the ratio is 10 to 1, while in chylomicron remnants, it's different, and in VLDL, the ratio is usually 5 to 1. So when you look to the lipid result, you can estimate by doing this calculation very quickly in the clinic, and then you can maybe think about which chylomicron is the causing this disease. And I think it's important to touch very quickly about the physiology of lipid metabolism. We know that dietary fat, when we take, so then we have triglyceride. Triglyceride need to have a transportation. So that's why there is, they will pack together phospholipid and cholesterol ester with triglyceride to able to transfer the triglyceride to inside the capillary lumen. I will not go in detail of all of this, but only I want to show that at the end, by lipoprotein lipase, it can be oxidized and form a smaller particle, which then can be recognized by the receptor in the liver. And again, for endogenous pathway, there is a production from the liver for this chylomicron. And we know in our diabetes, they will have overproduction. So that's why we'll see a lot of VLDL. And again, we need the lipoprotein lipase, which you can see it in the red, to cause oxidation. And then this can be again recognized and be taken by the liver. So if there is any disorder in this mechanism, it will cause a genetic hypertriglyceridemia. Like in case here, we can see that in this beta lipoproteinemia, for example, we know that is very important is the apolipoprotein E, which will be attached to the receptor. But you can see that E, it's a little bit deviated. So that's why the receptor will not recognize the lipoprotein and it will not be able to take it, and it will stay more in the circulations, and that will cause increased chylomicron remnants and will cause this beta lipoproteinemia, which we can see it present sometimes with tuberous xanthoma, which you can see in the clinic. For example, for familial hypertriglyceridemia, to understand, you can see the same lipid result between familial hypertriglyceridemia and familial combined hyperlipidemia. but the difference is about the size of the VLDL particle. Here you can recognize that VLDL is very big. So when you have big VLDL particle, those usually where we see the familial hypertriglyceridemia. Other than familial combined hyperlipidemia, which you can see here, we have a lot of chylomicron, which VLDL, it's increased production from the liver, and those more atherogenic because each of them carrying apolipoprotein B. So that's why it's very important to check apolipoprotein level in patient with hypertriglyceridemia, because if you have it high, so that means you think about uh, uh, combined hyperlipidemia, which they have premature atherosclerosis, and usually we target them much lower for their treatments in statin and to treat their hypertriglyceridemia earlier. So when you have a patient with low triglyceride, usually I think with low triglyceride, for example, 1.7, 1.8, or 2, you think maybe it's come from the LDL particle or HDL particle. While if you have higher number of triglyceride, you will think about chylomicron remnants or triglyceride-rich lipoprotein. That means IDL, VLDL, and chylomicron remnants. So those usually represent with a higher number of triglyceride. And for LDL, it will not be accurate measurements. So usually we will target the patient by using non-HDL cholesterol. And you can see here from the figure, non-HDL cholesterol, that means total cholesterol minus HDL cholesterol. This I put it again just to show the importance of knowing these classifications. You can see from type 1 to type 5 of hypertriglyceridemia classifications or hyperlipidemia that all of them, they have a high triglyceride except the type 2A, which have only total cholesterol. But is it matter to know what chylomicron or what the lipoprotein is here? You will have all this parameter is the same in your lipid panel. Is it important to know? Yes, because for example, here, if I have, let us take type 1, we have only one lipoprotein, which it is chylomicron increased. But if we take, for example, let us say mixed hyperlipidemia, we have VLDL and chylomicron. So we have two lipoprotein. So this patient carry more atherogenicity than chylomicronemia because he have VLDL there. And for combined hyperlipidemia, it's matter to check the ApoB. Again, you can know with high ApoB, you can expect that this patient have combined hyperlipidemia and he's more atherogenicity, carrying more atherogenicity. And even in some study, they said it can be more higher risk factor than hypercholesterolemia who only carry LDL particle. So it's very important, and in daily based, I use ApoB in my practice to be able to differentiate and be able to putting a right risk category for each patient. Here, one of the application which I find it very useful. I use it also in the clinic. You can download it on your desktop. Here you can, after you request the ApoB, you can put the number of ApoB and then the total cholesterol and the triglyceride number, and they can give you what the lipoprotein disease and what the expect syndromic, and then it can guide you more toward the diagnosis. And there is no doubt, as we know, the risk of hypertriglyceridemia on the cardiovascular system. And we know here in hypertriglyceridemia, the triglyceride-rich lipoprotein particle usually have a lot of triglyceride and they want to get rid from it. So usually they will give it to either the HDL particle or LDL particle. And this particle, when have more triglycerides, she will be more prone for oxidation, and that oxidation is causing her to reduce in her size and become more smaller and denser. So it will be excreted from the kidney. And that's why in hypertriglyceridemia, we saw patient come with low HDL. And that can cause, again, a red flag feature for ASCVD. And the other side, also for LDL, the same mechanism, they will accommodate more triglyceride and they will give them the cholesterol ester. So this particle will be more prone for oxidation, so it will become smaller and denser, and that will cause her to become more atherogenic. So we have a lot of data here which show that elevating of remnants can cause, it's an independent risk of low HDL. It's one of associated risk for ASCVD. So how we can start the treatment for those type of patients? So first of all is diet, ethanol reduction, weight loss, physical activity, then medicine and plasmapheresis in some cases, and gene therapy, gene editing, which are now emerging treatments. So before we go to all of that, for sure, we need to eliminate any secondary cause of hypertriglyceridemia. So usually we need to review all this cause, which can be the reason behind this patient hypertriglyceridemia before we jump into treatments. So what the usual advice I like to give to the patients? With the work with the dietitian, usually we try to restrict the fat intake and based on the number of triglyceride. So if the triglyceride less than 500, we'll say, okay, let us to do like the total calorie intake from the fat, not exceed like 30%. 30 to 35. And if triglyceride between 500 to 999, so that between 20 to 25%, and then triglyceride is above 1000, you can limit it to 10%, especially in case of chylomicronemia. It's usually very nice to work with the dietitian together and discuss about what the diet modification it can be done. And usually I involve in this type of discussion with the patient and the dietitian. Exercise for sure, like 150 minutes per week, and that can be a prescription also for the patients. Again, lifestyle, this is a main lifestyle change, which we recommend for the patient in the clinic. And then when we go over the medication, so which medication we need to start and when we should treat this disease. So based on this, the latest 2021 ACC expert consensus decision pathway of management of ASCVD risk, there is a very easy and nice pathway, which I make it like only you can see in this 4 group. I put it here on the left. So either the patient, when the patient come to the clinic, you think in this way, okay, is the patient have ASCVD or his diabetes or no ASCVD, no diabetes, like our patient who I present, or this patient have severe hypertriglyceridemia. So this is 4 main category. Then category number 1, ASCVD patient with mild to moderate hypertriglyceridemia. So what we need to do, usually if they have ASCVD risk, first of all, optimize LDL. So we need to optimize LDL to the target of the patient target. So this is another talk, which I will not go over this, but for sure you need to know your patient what LDL target based on the guidelines, and then try to optimize by adding a statin for this patient. Give the patient another visit to the clinic, see the effect of the statin on this patient, and then if the patient not reach his target of triglyceride, which it is normal target, so at that time only you can think about adding IPE or icosapent. So usually here in this stage, we talk about remnant disease. And remnant disease is usually defined as when LDL reach to its target. Number 2, patient with diabetes and with mild to moderate hypertriglyceridemia. So what we need to do? In this case, again, optimize LDL. So you need to think about the target. Is it less than 2? Is it 1.8 for this diabetes patient? So you need to start statin. Don't jump and start omega-3 or fibrate. I saw a lot of referral, a lot of patients being started on omega-3 for mild hypertriglyceridemia. So usually in the mild hypertriglyceridemia, we talk about the cardiovascular risk. So please optimize LDL, start statin, then think about adding icosapents. We know from reduced trial, icosapents have a very like 22% reduction in the cardiovascular endpoint. So that's good to start with icosapent 2 gram BID. So here you can see in this diagram, they divide the persistent fasting hypertriglyceridemia and then the patient who are age less than 50 year or more than 50 year with no additional ACVD risk. So those group are in lower risk. And usually in those group, there is no evidence to start icosapents on those patients because in reduced trial, all the patient who been included, they are either above age of 50 or they have at least one ACVD risk factors. So think about the age before you start icosapent for your patients and think about the risk factor. So start statin, optimize LDL, give a patient appointments. Some of in the guidelines say 4 weeks, and then you check from there to go. Third group, no DM, no SCVD, age above 20. So what we need to do in those category of patient, we need to estimate ACVD risk. So you can use one of the ACVD risk calculator, which it is, we know about it. So just do the calculator and see if the ACVD above 20, and then at that time, yes, you need to start intensify to high intensity statin therapy. If they are low ACVD risk, so only diet and lifestyle and predict the 10-year ACVD risk assessments. If they are here in the intermediate group, usually here consider initiation or intensification of statin therapy based on maybe more tests you will do for these patients as risk enhancement factors.
5 minutes.
Okay, so this is not in my talk because I will not cover the severe hypertriglyceridemia. And this is a nice diagram, just summarize all what I said. And this is what I say about reduced trial. So go back to the case who I saw it in the clinic. We remember that she's non-diabetes, non-cardiovascular. She have triglyceride 5.4 in more than 2 visits. So the guidelines said estimate ACVD risk plus minus statin. So just I wish if everyone kept his mental note. So just remember what your answer. So according to the guidelines, so we need to estimate ACVD risk and optimize LDL treatments. Thank you very much.
Thank you so much, Dr. Anada, for being exactly on time, actually a few minutes before your time. Thank you so much for this elegant presentation and overview. So we have Q&A after the 3 talks, so please place your question in the Q&A session. Now we'll move to the second related topic, which is hypertriglyceridemia-induced pancreatitis. And our speaker is Dr. Faisal Ahmed, who is endocrinologist from Dubai Hospital. Dr. Faisal have been involved actively in education of both undergraduate and postgraduate students and fellow, and have been or have taken a significant contribution to the medical community. So Dr. Faisal, I think he had registered a recorded talk. So please start the recorded talk.
Yeah, good evening, everyone. So today I'll be presenting a case, hypertriglyceridemia-induced pancreatitis. So history of the patient is a 48-year-old male who presented to the ER on February 21, 2023 with history of severe epigastric pain radiating to his back. And pain was associated with nausea and vomiting. Patient was in resident in Dubai for last 14 years and works as a taxi driver. He's a non-alcoholic. He smokes around 3 to 4 cigarettes per day for around 20 years. And coming to his medical history, he is a type 2 diabetes for around 8 years. He is on metformin, extra 750 milligram twice daily. He is an hypertensive for around 5 years. And he's on amlodipine 5 milligram once daily. And he's also dyslipidemic. He's on atorvastatin 20 milligram OD and fenofibrate 145 milligram OD. So he's a diabetic, hypertensive, and dyslipidemic. And we'll shortly go through his glycemic profile throughout his disease course. So even from the beginning, when we had his history, his diabetes is always under control, and his latest HbA1c was during just before admission was 6.4%, well controlled on only metformin. So coming to his past history, he has a recurrent history of HTGP since 40 years of age. So around 8 years, he is having the pancreatitis, which is induced by severe hypertriglyceridemia. And he gets admitted around 1 to 2 times per year. So there is a recurrent admission, and he does not show for his outpatient appointments. So he is, because of the financial and other issues and lack of education, so he's just maybe we are not sure whether he's following his medications regularly or not also. And after every discharge, his triglyceride during the discharge is around less than 700, except in one episode. So most of the time his triglyceride was reduced to less than 700, except a single episode during discharge was slightly above 700. And we will go through his triglyceride level during different admissions since 2014 to 2023. We will see around his highest triglyceride level was around 5,295, and during the last admission it was around 2,539. So most of the time it is around above 2,000, except 2 times he was around in thousands. So it's defining a case of severe hypertriglyceridemia. Coming to his surgical history, he has a history of lap cholecystectomy and open right inguinal hernia repair done in 2015. And coming to his examination, his blood pressure is 153 by 85 millimeter mercury. His pulse temperature was normal, respiratory was normal. He's around 160 centimeter height and weight of 70 kg. Saturation was normal. And he had an epigastric tenderness on examination. The rest of abdomen was soft with no distension. He had yield scar of previous surgeries. And the important labs during his last admission was his lipase was significantly elevated. And coming to his lipid profile, as discussed before, his triglyceride was from 2,539. And what we see here is LDL is only 8. So we know that in cases of severe hypertriglyceridemia, any triglyceride level above 400, the calculated LDL should not be done because of the false low value of LDL. So in this scenario, ideally, we should do a direct LDL measurement. And his blood sugars were normal. He had no acidosis, had mild hypokalemia with mild hyponatremia, no acidosis, and his CRP was normal, around 5.2. Other labs, what we see here is he had mild anemia, hemoglobin was 12.1, his platelet counts were low, around 57, and he had low vitamin B12. Ultrasound abdomen done during the admission showed a normal liver. CBD was dilated and no intrahepatic biliary dilatation was seen, and gallbladder is surgically removed. Pancreas appears normal in size and echo texture. The spleen was normal. There was no focal lesion seen. Coming to the hospital course, patient was admitted under general surgery as a case of pancreatitis induced by hypertriglyceridemia. And in hospital, he was kept initially in PO. He was then, as he was a diabetic and his triglyceride levels was very high, he was started on insulin dextrose infusion with clear fluids. He improved clinically. His diet was progressed until he was on oral feeds. He was kept on fat-free diet. As even with this, his triglycerides remained above thousands, and he was referred to medical service for further management. So the medical department advised to start on atorvastatin 40 milligram is and fenofibrate with omega 4 grams daily, which is the maximum dose, and along with insulin dextrose infusion. He was on insulin dextrose infusion for around 20 days. Triglyceride level did not drop even after the insulin infusion for the consecutive 20 days, and it was dropping very less, and decided to start a plasmapheresis, which was done on 6th of March 2023, and a second session was done on 13th of March after a week. There was a significant drop in his triglycerides, and is in between, after the first session of plasmapheresis, insulin dextrose infusion was stopped, because after plasmapheresis, his triglyceride dropped to less than 1000. And he was also reviewed by endocrinologist. They advised to continue him on oral medications as above currently, as his triglycerides have reduced. So for his platelets, low platelets, hematology consultation was done, and there was no evidence of ITP, and they did a platelet transfusion on 9th March. He had B12 deficiency and was started on oral replacement with Neurobion. He was also found to have mild iron deficiency anemia. Further workup for his low platelets and anemia was decided to be carried out once his acute condition was settled. And his platelet counts during discharge was around 82,000. And his blood pressure was well controlled with amlodipine. He was continued on metformin during discharge, and we maintained him on a fat-free diabetic diet. And during discharge, his triglycerides were less than 700, and he was discharged with the following medications. He was on omega-3 capsule, totally 4 grams daily, and fenofibrate, this is Lipanthil 145 milligram once daily, and pantoprazole and Neurobion 2 tablets for his vitamin B12 deficiency, and atorvastatin 40 milligram, half tablet was given, and amlodipine 5 milligram was continued for his blood pressure. So summarizing the case, it was a case of severe hypertriglyceridemia with recurrent admissions for pancreatitis, and during each episode he was given medical management, and during his latest admission he was given insulin dextrose infusion along with pharmacological other oral medications, but he required a plasmapheresis, since even after 20 days of insulin infusion there was triglycerides was not coming down to less than 1000. But his clinical condition, irrespective of his triglyceride level, improved drastically within few days of admission. So coming to the literature review of HTGP, coming to epidemiology, HTGP causes around 1 to 35% of all cases of acute pancreatitis, and up to 56% of pancreatitis cases during pregnancy. Hypertriglyceridemia is the third most common cause of acute pancreatitis, and the risk of acute pancreatitis increases progressively with serum TG level over 500. and the risk increasing markedly with levels over 1000 milligram per deciliter. So any patient with a TG level of 500 is at risk of acute pancreatitis, but once it reaches 1000, his risk markedly increases. And the risk of acute pancreatitis also increases with number of prior episodes of acute pancreatitis. So each episode increases its chance of another episode. And the degree of triglyceride elevation is associated with severity of acute pancreatitis. So the higher the TG level, the severe the presentation of acute pancreatitis. There are other factors also involved to influence the severity of the acute pancreatitis. One is pancreatic lipase activity, the efficiency of clearing fatty acid from the serum, and the severity of the underlying pancreatic injury. So these are the other things which can influence the severity of acute pancreatitis in HTGP, along with the level of the triglyceride. And a quick summary of the causes of increased TGL. One is it's divided into two, primary and secondary. Primary are familial conditions. Secondary common causes are CKD and nephrotic syndrome, CLD, drug-induced. Multiple drugs can cause pancreatitis, including antipsychotics, beta blockers, steroids, estrogens, immunosuppressants, protease inhibitors, tamoxifen, and thiazide. And hypothyroidism, excessive alcohol consumption, metabolic syndrome, and other disorders like glycogen storage disease, multiple myeloma, and SLE. What we see here is multiple familial syndromes, multiple familial disorders like familial chylomicronemia, familial combined hyperlipidemia, dis-beta lipoproteinemia, and familial hypertriglyceridemia, and familial hypoalpha lipoproteinemia, and primary genetic susceptibility. These form the primary, and during the subsequent slide, I will explain when to search for unfamiliar disorder in when TGL levels are high. So coming to the pathogenesis, this is a very important slide. An increased triglycerides will increase serum chylomicrons, and this will increase the serum free fatty acids, and free fatty acids aggregate into micellar structures which cause damage to the platelets and vascular endothelium, which can cause ischemia and acidosis. Also, plasma viscosity is increased, which causes capillary plugging, and again it contributes to ischemia and acidosis. This can directly cause acute pancreatitis, or it can also activate trypsinogen, which can cause acute pancreatitis. Clinical presentation, the symptoms are similar for any cause of acute pancreatitis, which includes abdominal pain, and it is acute, sudden, knife-like, severe, mostly in epigastrium and sometimes in the right hypochondrium. There is radiation of pain to the back. Sitting up and bending forward may reduce the pain, and nausea and vomiting. Others like fever, GI bleed, and dyspnea, depending on the severity. Signs include patient appears usually acutely ill, marked abdominal tenderness, shallow rapid respiration can be there. He can either present with hyper or hypotension, including postal hypotension, may have limited diaphragmatic excursion, can have an abdominal distension, ileus with decreased bowel sounds, altered mental status, and jaundice in severe cases. Clinical presentation includes most adults with HTGP present with symptoms in the 5th decade of life. However, patients with certain inherited disorders, like what we showed, like familial syndromes, familial disorders, can develop attacks of acute pancreatitis in early childhood or adolescence. So any patient with acute pancreatitis due to hypertriglyceridemia in a younger age should look for a familial cause. What we see here is the physical examination findings specifically for HTGP. We can have a tubereruptive xanthomas, tuberous xanthomas in the extensor surface in the elbows, and we can have lipemia retinalis, hepatosplenomegaly, and xanthoma striata palmaris. And this is a blood sample from a patient with triglyceride level of around 1200 in a serum separated tube. So at such high triglyceride levels, the serum becomes lactacin. And lab findings in HTGP, we have an elevated TG levels. Also, it can alter the routine measurements of sodium, glucose, amylase, and LDL. As I discussed before, excess TG in a serum sample can displace water containing sodium and cause pseudohyponatremia. Serum TG more than 500 may cause falsely normal amylase levels, likely from interference of calorimetric reading. And serial dilutions of serum amylase sample can reduce the triglyceride interference. Coming to the diagnosis of HTGP. HTGP should be suspected in patients with acute pancreatitis and risk factors for hypertriglyceridemia. And whenever the TG levels are more than 500 in a patient with acute pancreatitis, should suspect that the hypertriglyceridemia is a cause of acute pancreatitis, and a value of above 500 is required for the diagnosis to be considered. And acute pancreatitis by itself does not cause significant hypertriglyceridemia. And coming to the diagnostic criteria for acute pancreatitis, we should have two of the following. One is increase lipase 3 times the upper limit of normal, or an abdominal pain which is consistent with pancreatitis, and abdominal imaging which suggests pancreatitis. Imaging doesn't need to be performed in every patient with pancreatitis. So we do an imaging when symptoms fail to resolve, diagnosis remain in question, concern for pathology complications including peripancreatic abscess, pancreatic pseudocyst, necrotizing pancreatitis, pancreatic mass, and biliary obstruction. Now, coming to the management of HTGP, initial management includes treatment of acute pancreatitis and reduction of serum TG levels with the goal of preventing necrotizing pancreatitis and organ failure. In patients with HTGP, maintenance of TG levels below 500 may expedite clinical improvement. And we have to assess for the worrisome features, which include temperature more than 38.5, heart rate more than 90, respiratory rate more than 20, or PaCO2 of less than 32, WBC count of more than 12,000 or less than 4,000, or more than 10% immature band forms. General measures in all patients with pancreatitis includes treatment of acute pancreatitis, which is through diet, either NPO or soft diet or IV fluids, keeping him on NPO, pain management. So I don't want to go into detail with the acute pancreatitis management here. We'll stick to the HTGP. And in HTGP, we have dietary fat restriction, which plays an important role in reducing the triglycerides. Usually the diet with less than 5% fat is prescribed. And we have to remove the secondary causes of hypertriglyceridemia, including medications or treating is hyperglycemia, diabetes, and other reasons. And additional measures, coming to additional measures in selected patients, we have plasmapheresis. As in our patient, we had plasmapheresis 2 sessions to reduce the triglyceride levels to less than 1000. You should reserve the use of plasmapheresis in patients with HTGP with worrisome features, which I described before. And a single session of plasmapheresis has been reported to lower TG levels by 50 to 80%. However, the issue with plasmapheresis is there is no studies demonstrating an improvement in the outcomes in patients with HTGP. Plasmapheresis does not appear to improve outcomes in uncomplicated cases of HTGP. In patients treated with plasmapheresis, TG levels should be measured after each cycle of plasmapheresis. And plasmapheresis should be discontinued until once the TG levels are below 500. And coming to the second option we have is insulin. It's used in most of the centers as most likely like standard of care. We administer insulin in patients with, again, worrisome features of HTGP, in whom plasmapheresis is indicated but is unavailable or cannot be tolerated. Insulin can decrease both TG and glucose levels, and also we also administer insulin in patients with HTGP with diabetes to manage hyperglycemia. In patients with worrisome features, we have to initiate an IV infusion of regular insulin at a rate of 0.1 to 0.3 units per kg per hour while closely monitoring blood glucose levels. Also, when the blood glucose levels reach between 150 to 200, we can administer a separate line of 5% dextrose to prevent hypoglycemia. And TG levels should be monitored every 12 hours. Like we monitor after every session of plasmapheresis here, every 12th hourly we monitor, and glucose hourly as patient will be on infusion, and dextrose infusion the dose should be adjusted accordingly. Again, IV insulin should be stopped when TG levels are less than 500. And how the insulin is useful in HTGP, what we see here is insulin reduces VLDL triglyceride production and lowers serum TG levels by enhancing lipoprotein lipase activity, an enzyme that accelerates chylomicron and VLDL metabolism to glycerol and fatty free acids. It inhibits hormone-sensitive lipase in adipocytes, which is the key enzyme for breaking down adipocyte triglyceride and releasing fatty acids into the circulation. The goal of insulin therapy in severe acute pancreatitis associated with severe hypertriglyceridemia is not reducing the TGA level. Basically, the most important role is to reverse the stress associated release of fatty acids from adipocytes to promote intracellular triglyceride generation within adipocytes and to promote fatty acid metabolism in insulin sensitive cells to reduce peripheral insulin resistance and to correct hyperglycemia. So when we compare plasmapheresis with insulin, the studies analyzing the effect of plasmapheresis for HTG associated acute pancreatitis have been scarce with generally low sample sizes. But several studies have shown that plasmapheresis is an effective tool for lowering TG levels. And plasmapheresis is theoretically effective in removing triglyceride from plasma, but whether it confirms clinical benefits is unclear. And plasmapheresis usually requires a large center, more invasive, and generally more expensive compared with insulin therapy. Not all centers can have a plasmapheresis. On the contrary, insulin therapy is readily available and can be used safely in various settings and different levels of care. Therapies lacking efficacy, heparin do not use heparin due to transient nature of reduction of TG levels, potential hypotoxicity from the intravascular release of free fatty acids from heparin-induced lipoprotein lipase-mediated hydrolysis of TG-rich lipoproteins, and an increased risk of bleeding. This degradation contributes to further depletion of plasma stores of LPL and can result in an increase in the level of VLDL and chylomicron triglycerides. Subsequent management, once the triglycerides reduce, we search evaluation for the modifiable risk factors for the secondary causes. And whenever the hypertriglyceridemia is not clearly associated with the secondary cause, family members should be screened with a fasting triglyceride level. And coming to the lipid management, patients recovering from STGP require long-term therapy to prevent recurrent acute pancreatitis and to prevent other complications of increased TG. This consists of both pharmacologic therapy and dietary modifications with restriction of fat content to 10 to 15% of the diet and avoidance of concentrated sugars. Other measures include weight loss, who are obese, aerobic exercise, avoidance of medications that raise TG levels, and strict glycemic control in diabetes. So this is the general approach to a patient with HDGP. So you have to manage an acute pancreatitis with IV fluids and pain control. Assess whether the patients with HDGP have any one of the following: whether he has an hypocalcemia, he or she, lactic acidosis, 2 or more signs of worsening inflammation, which I discussed earlier, or worsening organ dysfunction or multi-organ failure. If the patient has any one of the above features, we have to initiate a plasmapheresis and monitor TG levels after each cycle. Discontinue plasmapheresis when serum TG levels are less than 500. Severe dietary fat restriction, fat content less than 5% of diet until TG levels are less than 1000. When serum TG levels is less than 1000, initiate long-term pharmacologic and non-pharmacologic measures to lower TG. This is basically because if it is TG level is more than 1000, it is mainly a chylomicron is present. So the drugs doesn't lower the TG levels. When it is less than 1000, we have VLDL triglycerides, which drugs can lower. And in settings where plasmapheresis is unavailable or patient is unable to tolerate plasmapheresis, you can initiate IV regular insulin, monitoring glucose levels every hour and triglyceride every 12 hours, and discontinue the infusion once triglycerides reach less than 500. In patients with HDGP and no features of hypercalcemia or no lactic acidosis, no worsening inflammation, no inflammation or no other organ dysfunction, multi-organ failure, stable patient, check whether the patient is having diabetes, hyperglycemia or no. If patient is having hyperglycemia, you can start regular insulin IV, same monitoring glucose and triglyceride every 12 hours, and discontinue insulin once TG levels are less than 500. And once less than 1000 TG, you can initiate the pharmacologic and other measures. If patient is not having hyperglycemia and is stable, you can maintain the patient only with severe dietary fat restriction. And once serum TG is less than 1000, you can initiate medications. But you have to monitor with even dietary fat restriction the triglycerides every 12 hours until the triglycerides are less than 1000. Thank you.
Thank you so much for the excellent presentation, Dr. Faisal. Dr. Faisal will join us in the Q&A session. So please, if you have any question, just write his name before your question in the Q&A section. So now we'll move to the third talk, and the title will be Navigating Cardiometabolic Health Literature Review. And our speaker is Dr. Asma Al-Jabri, who is consultant endocrinologist at Tawam Hospital and adjunct assistant professor at the College of Medicine and Health Science. Her field of interest in endocrinology are osteoporosis, bone metabolism, obesity, and lipid metabolism disorders. Thanks for joining us, Dr. Asma, and please share your presentation.
Thank you, Dr. Araya, for the kind introduction. I'm sharing my slides. Do you see my slides now?
Not yet.
Do you see them now?
Yes. Just presentation mode.
Okay. So good evening, everyone. My talk today is going to be about cardiometabolic health, and I'll take you through this, and I hope that I'm going to be on time. I don't have any disclosure. My objectives for tonight is going to be presenting a clinical case representing a cardiometabolic burden of diabetic patients, and through that, we'll take you through the cardiometabolic health and cardiovascular burden. We're going to talk about the most common, the cardiovascular outcome trials. Then we'll talk about the challenges and future directions. Then ADS and ASC cardiometabolic guidelines, and we'll go briefly through the TWAM cardiometabolic clinic. So without any further ado, we'll start the case. This is a SN 66-year-old Emirati female patient who presented to my clinic with a clinical history of hypertension, hyperlipidemia, type 2 DM, CKD3B, morbid obesity with a BMI of 45, fatty liver, coronary artery disease. She's a status post-CABG in 2015, and PCI new event in October 2020. She's having hypothyroidism and obstructive sleep apnea. Her medication list include amlodipine, moxonidine, nebivolol, prindoprel, atorvastatin, ezetimibe, linagliptin with metformin, clopidogrel, levothyroxine, and CPAP, but she was not compliant. So just a thought when you see someone like this patient. So I was thinking, given the multiple interconnected comorbidity, how do we best classify the risk of the cardiovascular in such patient? And what are the best strategies for optimizing the cardiometabolic health? So let's start asking ourselves, is SN at increased risk for a future cardiovascular event? Yes, no, or unsure. So if we're going to our first visit, looking at her parameter, her heart rate is 69, so the target should be less than 70, blood pressure is 129/78, and the target is less than 130/80, weight is 127, BMI 45, waist circumference 135, pedal pulses were present, and the ankle brachial index is 1.05. I just need to mention here, all this done on any cardiometabolic patient coming to the cardiometabolic clinic. ECG showed no ischemic changes, and the edema score was decreased functional capacity. eGFR 37, LDL 1.7, TG 2.5, hemoglobin A1C 7.5, postprandial glucose 200, between 200 and 250. MP was not done at the first visit, so it was ordered. And echo normal with ejection fraction of 60 to 65, but she was having grade 1 diastolic dysfunction. So what factors are contributing to SN cardiovascular risk? Hypertension, type 2 diabetes, morbid obesity, obstructive sleep apnea, and high LDL. So she's having the full package of all the risk factors for the cardiovascular disease. So going to the first LDL reading during the first visit, 1.7. What do you think? Does LDL level fall within the LDL range that confers cardiovascular risk? You need to ask yourself, yes, no, or unsure. Okay. So to take you through this, we're having a concern when we see such patient. what is the best, what is the patient's risk for cardiovascular disease in the next 10 years? How to manage this patient's hypercholesterolemia, and what classes of cholesterol-lowering medication are available? What is the best cholesterol-lowering medication for this patient? So if we're going through the European Society guidelines, how to treat patients with cardiovascular disease and the hyperlipidemia, we can look at how they categorize the patients to low, moderate, high, and very high, and extremely high risk. So you need to look where your patient falls in this category and look at the cutoff. For example, if the low, less than 3, moderate, less than 2.6, high, less than 1.8, very high, 1.4, and extremely high, less than 1. So let us go back to our patient. What is her risk? So the patient falls, if we're going to this, you will see that she already has established cardiovascular disease that immediately put her in a very high risk category. Not very high because she didn't have 2 events, extremely high because she didn't have 2 events in the 2 years. Then our target is to have 50% reduction of LDL and to achieve the less than 1.4. So it is not or, it should be at. So our patient LDL is 1.7. So if we're achieving less than 1.4, it should be also 50% less. That's mean around 0.8 something. 0.7, sorry. So concepts for lipid lowering treatment. So we need to define our risk. So our patient is having very high risk. Define the LDL goals. So our patient's goal should be less than 1.4. And then you should choose the best lipid lowering strategy for treatment of her hypercholesterolemia. High intensity statin, then you need to repeat LDL in 4 to 6 weeks. If the patient is not achieving the target, you need to add ezetimibe, then remeasure again in 4 to 6 weeks. And the patient is not achieving, you need to add PCSK9 targeted therapy. So you're here with this patient. She's already, if you remember that she's already on high intensity statin, atorvastatin 40 and ezetimibe. So you're already done with this and you need to move further. I mean, here I'm just stating what is the intensity of medication and how much they're expected to lower the LDL. If you remember, the guidelines says that it should be 50% reduction of LDL. So you will not choose moderate intensity or low intensity. You should start with a high intensity statin to achieve your target. So your patient is already on high intensity statin with ezetimibe, that is together should give her 65% reduction, but you need now further reduction. So if you're starting PCSK9 inhibitor per se, it's going to be 60%, but if you're going to add it to high intensity, it's going to be 75%. If the 3 medication together, around 85% reduction. So going back to our patient, would you add PCSK9 targeted therapy? I think you would answer, your answer is going to be yes. And this is also based on the European guidelines that if you're having a patient with a very high cardiovascular risk, you should start from the beginning as high intensity statin with ezetimibe, then remeasure in 4 to 6 weeks. Patient should achieve 50% reduction with the target of less than 1.4. If you're happy with that, then you don't need to do anything. But if it is still higher than that, then you need to add PCSK9 inhibitor. And this is the case with our patient. So in visit 2, 3 months after, this patient was started on inclisiran. And for the first time, she's coming with LDL 0.04. So she achieved LDL for the first time, match the risk of cardiovascular, matching her risk for cardiovascular disease. So are you worried about very low LDL? So from meta-analysis collected from Mendelian randomization studies, prospective cohort study, and randomized control study all shows that the lower the better. So whenever you're having the chance to lower the LDL more, that's going to be better for the patients because it's going to reduce their cardiovascular. And from many studies were checking the side effect of the low LDL. They didn't find any side effect. There was a concern regarding cognitive function, but didn't show any risk with lower LDL. So how we're doing now in attaining the goal of LDL goal for the patients with matching their risk. So previously in 2016, if we're looking at the guideline, physician, we're doing at least better than now, 54%. But with the new guidelines, only 33% of patients are achieving their target LDL. And there are many causes. The majority of patients were receiving moderate intensity statin, and this is actually published in Cochrane study, Da Vinci study in 2020. So most of these patients were prescribed moderate intensity statin. Only 28% of them were receiving high intensity statin as a monotherapy, and few patients were receiving ezetimibe combo, and very small number of patients, less than 1%, they were receiving a combo with PCSK9 inhibitor. So what combination can help us to get our goal? And here you can see that 58% based on the new guidelines, 2019, achieved their goal on when they have the PCSK9 inhibitor or PCSK9 targeted therapy. Okay, so we're done with hyperlipidemia. What about her diabetes? Again, her hemoglobin A1C, if you remember, it was 7.5, and she was on linagliptin. So addressing her cardiovascular disease, and based on the guidelines, we need to switch her to a medication which can offer her cardiovascular protection. So I switched her to metformin 5,000 BID. Follow up in 3 months, her hemoglobin A1C improved from 7.5 to 7. CKD stage 4, EGFR 37, ACR is high. I started her on dapagliflozin with the combo with metformin. So expected to have a dip in the first month. So I checked her EGFR 1 month after starting dapagliflozin, it went down to 27. And 3 months, it went back to baseline. Okay, morbid obesity. Patient's BMI is 45. She's having morbid obesity. I started her on GLP-1 agonist, added on her medication. She lost 5 kg, felt much better, started to mobilize out of the wheelchair. What about obstructive sleep apnea? She was not compliant on her CPAP. We addressed the importance of weight reduction and compliance on CPAP use. I sent her to outside facility where she can have customized different CPAP masks which fit her. And after 3 months, she lost weight. She became compliant on CPAP, breathing better and sleeping well and waking up fresh. So this is an example of a cardiometabolic case, which you might see on your daily basis. But if we're looking at the literature and even in our clinical practice, we can understand that there is a concern in managing those patients. Most of the internists, if you're not a cardiologist, or if you're not a nephrologist, you're going to concentrate on management of type 2 diabetes. But what about the management of cardiometabolic other disease? And how you would do in preventing this? So we're having a failure, and we're having a reason for failure. There is a clinical inertia. Our concern always a hemoglobin A1C and the target. And we're worried about the hypos and weight gain with medication. Old medication strategy were not effective in treating diabetic patients. And there is other factor not adequately controlled on such patients. If we're looking at the prevalence of the diabetes worldwide, it is 536 million of people living with diabetes. That's mean 1 in 10. And the expected in 230 to go up to 642. There is an increase of around 1%. And in 2045, it's even much worse because it's going to be 784. In the UAE, the prevalence of diabetes based on the IDF 2021 12.3. So any diabetic patient is having, with the chronic hyperglycemia, might start to have vascular injury, microvascular disease, retinopathy, nephropathy, and retinopathy. With the chronic exposure to hyperglycemia, not controlling the cardiovascular risk, for sure, the patients might start to have the macrovascular disease. So this is what we see in advanced uncontrolled diabetes. Patients might have both macro and microvascular. So our conventional treat at failure failed to reach the target. And if you can see in the left side graph, this is what we used to do before. Start with the diet, wait, the patient is going to have high hemoglobin A1C, start monotherapy, then wait for another visit 3 months, then do combined therapy, then start basal insulin, then start MDI. And now we're moving to different approach, early combination approach. So diet and oral therapy, then a combination, hit together, then that will lead the patients at least to the target, keep the patients on the target for a long period of time. Then after that, you can up-titrate your oral therapy. Then again, the patients might go to the target. Then again, you will add the basal. But see the patients, at least here, the patients was achieving the target faster and staying in the target for a longer period of time. So there is a multifactorial intervention to reduce the risk of complication and diabetes, not only controlling the glucose, but we need to think about weight management, blood pressure monitoring, dyslipidemia, and the platelets inhibitor. And there are many studies have been done in this field to address the cardiovascular complication of diabetes and the risk of mortality, and how we're decreasing the risk of mortality in such patients. And if we can look at the numbers and the studies, we can see that the cardiovascular can occur even before the diabetes diagnosis, way before. And there was a study actually looking at this, there we're talking about 5 to 10 years before the clear diagnosis of diabetes. And the patients might develop microvascular atherosclerosis before that. 50% of death and the death of diabetic patients are cardiovascular. And that happened in pre-diabetes stage, not in diabetes. And that's mean it is not the high glucose, the leading factor for the death or cardiovascular, the death in such patient. There must be another factor of metabolic syndrome. High BMI, waist circumference, bad food choices, and smoking. And there is a study published in JAMA talking about the association of body mass index with the lifetime risk of cardiovascular disease and compression of morbidity. So the longer the patient is living with obesity, for example, it's going to affect the cardiovascular disease risk. So let's look at the obesity as a risk So we're having a significant burden of obesity. Worldwide, we're having 764 million living with obesity. And this expected to even go higher, expected to be 1 billion of people living with obesity, and a prediction of 2030. And in the UAE, prevalence of obesity, this was taken from the World of Obesity Statistics from 2018. We're having an adult of 27.8%, men 25.1, and 30.6. And if we divided them to Emirati population, it's going to be even higher. So Emirati male, 38.5 living with overweight, 32.2 living with obesity, and women 29.3 overweight and 41.8 living with obesity. And you can imagine the calculation of this number. And the prevalence of the obesity in the UAE and the expected increment in the prevalence, it's expected to increase by 1.5 in adult and 2.5% annually for children. Adult male rank 26th by 28.44 worldwide, and adult female rank 20th worldwide. So how we address all these cardiovascular risk in our patients? From 2008, it was mandatory to conduct a cardiovascular outcome and safety for medication trials, and we're having so far many cardiovascular trials came out over the years from 2013 till even 2024. So if we're looking at the cardiometabolic trial, which showed that there is a good efficacy in reducing the death in diabetic patients, we have EMPA-REG, and we're having a LEADER study. So EMPA-REG, they were looking at the cardiovascular death, non-fatal MI, and non-fatal stroke, and LEADER we're looking at the same time, the same parameters. So if you look at this, there is a significant separation of the line early on in the study. In the EMPA-REG, and EMPA is SGL2 inhibitor, and LEADER GLP-1. There is a separation, but occurs a bit later. So most likely, the reason why the patients had, it's more like a functional, and here it's more like it works on the atherosclerosis level. If we're going now to the guidelines, so the guidelines understood that there is a significant problem with the diabetic patients, and with having a cardiovascular outcome trial, they have to update their guidelines. So before 2008, the main target was hemoglobin A1C, and the strategy, the lower is the better. From 2008 to 2018, the lower the better, but without hypos and weight gain. From 2018, we started to concentrate on the cardiovascular protection with renal also protection. So we're looking at the blood pressure, LDL, glucose, use of agents that have proven safety and efficacy, covering the other cardiovascular factors. And this is how the evolution of ADA and ASD guidelines, for example, this is what I just mentioned. From 2015, the approach was only for to treat non-specific and preference for treatment only of diabetes. From 2018, started to talk about the cardiovascular CKD and heart failure, GLP-1 receptor agonist, and SGL2. And now we're having even better understanding, especially that we're having now in type 2 diabetes with or without established cardiovascular, but with heart failure and or CKD, we need to consider SGL2 inhibitor, and with the patients with high cardiovascular disease and diabetes, GLP-1 agonist. And this is ADA ESD guidelines. And if we're looking at if the patient having a cardiovascular disease or indicator of high risk, so it's either to start GLP-1 receptor agonist or SGL2 inhibitor, preferred for such a group. And if the patient is having CKD, preferably to be started on SGL2 inhibitor, followed by GLP-1 agonist. So we talked at the past, and today what we're facing, and we're waiting for the next indications. So now, for example, GLP-1 agonist is indicate use only for diabetic patients, but recently even for the cardiovascular. And the new indication would include for sure muscle, congestive heart failure, and the prevention of CKD. And the indication also for congestive heart failure and CKD. And this is what recently published, that the SELECT study, one of the studies showed the decrease of the cardiovascular disease. And I need to mention that still in the UAE, the semaglutide 2.4 is not approved for the cardiovascular, but in states now it's approved for cardiovascular, even without the diabetes. So those patients with cardiovascular disease started on, without diabetes, started on semaglutide 2.4, and you can see the separation of the line early on, and there the risk reduction or MACE was 20%. So we talked about the burden of the disease, and if you look at this study was published in JAMA 2019, and addressing all the cardiovascular risk complication of diabetes. And if you look at the graph, it's showing you nicely that we're doing better an age of 65, the risk is decreasing, but from 2010, they started to plateau. But if you look at the younger age and middle age group, the risk was decreasing, but in 2010 it started to increase in a younger group and a middle age group. So that's indicating that we need to work harder on younger and middle age group. So another study published in New England Journal of Medicine, they were looking at the prevalence of glycemic blood pressure and lipid control among adult participants. And they were looking at how much we're achieving the target. For example, hemoglobin A1C less than 7, achieved on almost 50%, blood pressure less than 130/80, achieved by 47.7, and non-HDL less than 130, 55%. But if you're taking all the targets together, there's only 22% of patients, of adult US patients with diabetes have all the 3 targets factor controlled. And if we're looking at a medication, how we're compliant with the prescribing the right medication for such patients and how much we're compliant. So this study published in the New England in JAMA, we're looking at how much cardiovascular disease patients compliant with taking the medication. For statin, 57% only, AC inhibitor or ARB, 45%, GLP-1 agonist, 3.9, and SGLT2 inhibitor, 2.8. So received all of these in a patient's diabetes and cardiovascular, only 4.6% of patients. And 42.6 were prescribed none. That's lead us to one thing, that when you see patients with diabetes, you need to look at all the patients' comorbidities, and you need to build your decision based on the other risk factor for cardiovascular disease, and treat the patients in holistic approach to early control and individualize the treatment. The holistic person-centered approach by Diabetes Care is very nice guide how to deal with these patients. Their way is to address the medication, good for glycemic control, weight management, cardiovascular risk factor management, and cardiovascular choice of glucose lower, cardiorenal protection, choice of glucose lowering medication. So you can go through this graph, in details, but it is one of the best guide how to go through the holistic approach. So again, it is adapted from the ADA-ASD guidelines. If the patient is having high cardiovascular, you would add GLP-1 agonist or SGLT2 inhibitor. If the patient is having heart failure, SGLT2 inhibitor with a proven heart failure benefit in such population, and CKD, SGLT2 inhibitor or GLP-1 agonist. So how can we do better? There is there's a huge or significant importance to deal with those patients and a very holistic approach. So what happened nowadays? Your patient is seen by multiple subspecialty, GP, endocrinologist, cardiologist, nephrologist. So we need to unify this. Any one of them can be a cardiometabolic. GP can be a cardiometabolic if he's addressing all the risk factor of his patients. For sure, we should have a good training how to address all our patients' risk factor. And we need to understand that cardiometabolic disease is a public health problem. And this is what EDS and American Cardiology Society understood very well. And they they published recently their cardiometabolic guidelines. This is a screenshot of the UAE cardiometabolic risk score, scoring how to score your patients. It's going to be based on the age, duration of diabetes, if the patient is having risk factor for cardiovascular, and if the patient is having multiple risk factor. And that's going to classify your patients as low, moderate, high, or very high risk. And this table is very important for all of us, how to manage cardiometabolic patients. So my patient was very high risk. Let us see if there is any difference of what we've done. Start the patients with type 2 diabetes. So we need to start SGLT2 or GLP-1 agonist. Blood pressure target, less than 130/70. You need to start AC inhibitor or ARB, and the LDL target should be less than 55, and you need to start high intensity statin, then escalate it based on how much you're achieving your goal, and antiplatelets is indicated. And in Tuam Hospital, we also understood the importance of treating such patients in very holistic approach. And we started our cardiometabolic clinic, where the patient is seen by a cardiometabolic, by endocrinologist, cardiologist, referred to dietitian, diabetic educator, nurse, and a clinical pharmacist. And if there is any need, especially post-cardiac event, for rehab, cardiac rehab, if there are any stress events or psychological status stressor, we're referring to behavioral psychologists. So in conclusion, there is an interplay between metabolic risk factors, CKD, and cardiovascular, premature mortality due to increased cardiovascular mortality with obesity and DM epidemics, earlier development of cardiometabolic factors, and aerial presentation with cardiovascular disease. And the key opportunities is better scientific understanding, multiple new therapies that simultaneously impact DM, kidney, and cardiovascular outcome, and the care model must focus on a holistic approach and include the integration of multiple healthcare disciplines. With this, I'm coming to the end of my presentation. Thank you.
Thank you, Dr. Asma, for this comprehensive overview. Now I invite all the speakers to the Q&A session. We have a few questions. I will try to direct. We have Dr. Nada with us and Dr. Faisal as well. Welcome, Dr. Faisal. He is with us live on Q&A session. So we'll try to go through the questions. We have some interesting questions, actually. So to start with you, Dr. Nada, there is a question in regards to the, it is actually in regards to the measurement of ApoB. So the question, you stressed a lot on the measurement of ApoB level in patient with hypertriglyceridemia. Why is that? And what about lipoprotein little a? Do you feel doing both will reach the patient to a better clinical outcome?
Yeah, thank you for the question first. As I said in the talk, like usually measuring ApoB lipoprotein is if you have case with hypertriglyceridemia and you want to put a diagnosis and you want to see the cardiovascular risk. So ApoB usually, as I said, if it is high, like if it is above 120 by milligram per deciliter, or it is above 1.2 gram per liter, so that carrying a red flag. So that means that you have a lot of lipoprotein particle with a lot of ApoB. So more ApoB, like with the same LDL level, with the same triglyceride level, with the same cholesterol level. So you will not know which one is higher risk. But by measuring this, you can know which patient you are dealing with. So that can help you to understand more what the chylomicron, the lipoprotein particle you are dealing with. And then it can implicate like about design what the treatment you will put and what the response of the treatments. So that's why I order ApoB, and also it can be used as a target when you have when you are lowering your LDL. As we know, we can use LDL target, or we can use non-HDL target, or we can use as ApoB as a target for your statin managements.
Excellent.
For lipoprotein little a, yes, it's very useful tool, which usually we use it in the patient who have personal risk, like FH patients, or patient came with premature heart disease, or in patient who have family history of premature heart disease in one of his family. So usually I send this test. And the patient also, when you put a risk category, when you calculate the risk, and then you have intermediate group, again, those as one of the risk enhancements factor, it can help you to guide you toward the intensification of management, or if you don't want to treat like intermediate group.
Excellent. Thank you so much, Doctora. There is another question for you, Dr. Faisal, regarding the good question actually. How much do you expect reduction in triglyceride with the IV insulin, and how long it takes? How many days to resolve the severe hypertriglyceridemia? The IV
Yeah.
insulin.
Actually, there are many studies which have compared regarding the insulin infusion with the other standard treatment, only with diet management and other pharmacological therapy like statin. What we have seen here is recent studies have shown that at least by 1 to 2 days, we have a faster recovery from hypertriglyceridemia. Even latest study in 2023 I was going through, it was showing that around mean period was around 2 days for without insulin infusion. But what we see practically in some cases, we don't know what is it like, depending on the level of triglycerides. Some cases it takes time, lot of time, or sometimes it doesn't work out. But mostly it takes 2 to 3 days earlier than without the when we compare with only with the diet control and other things. And we expect, like as I said, plasmapheresis, we have a standard rate of 50 to 60% with every session. But with this, we usually expect around 20% decrease. But it all varies. We don't have any standardized data for insulin infusion either. And as we said, for insulin infusion, the main role for us is not to reduce the triglycerides. It is the many other actions like LPL, lipoprotein lipase activation, and other things. So usually to prevent the more complications of the pancreatitis, not for it. One of the effect of insulin is to reduce the triglyceride, but our main the concept for using the insulin infusion is to prevent the further damage of the pancreas, not as the plasmapheresis,
So
which
there is
the triglyceride.
I see. So there is another related question because it is in the same context. So related to that, there was a question whether there is a prophylactic that we have to move immediately to plasmapheresis in patients with severe hypertriglyceridemia, for example, unrecordable, with history, for example, of TG-induced pancreatitis. Do these patients we go directly to plasmapheresis as we expect to try insulin, IV insulin will take time? Yeah,
see, if available, if patient is having worrisome features, as I discussed with the complications, is directly going for plasmapheresis, it's the best option rather than going for the IV infusion, because it takes time. Plasmapheresis is very efficacious, but the only issue is not all centers will have the plasmapheresis. And one more thing we have to consider, not having a plasmapheresis is not going to be a detriment, because no studies have proven that doing a plasmapheresis as really increase the outcome, but definitely it decreases triglyceride. But currently what we have is data is going for plasmapheresis as early during when we have an opportunity to take for the plasmapheresis, because it is reducing the triglyceride. Plasmapheresis is more efficacious than the IV insulin.
Thank you so much. Dr. Asma, there was a question in regards to the, actually, maybe this is, I'm not sure if why this patient, the case that you presented was started in inclisiran, why not in iliricumab or evolocumab? So they were asking if there is any specific policy in UAE, which one to start after statin and ezetimibe.
So, all the medication are approved for secondary prevention. So we're talking here about secondary prevention, but it depends more on patients' also preference. So this patient was started on GLP-1 agonist. So when I offered her evolocumab, she was not happy to take weekly injection along with every 2 weeks injection. And then we went to inclisiran.
Absolutely. There is another question. Which drug do you start first? SGLT2 inhibitor or in such complex case, or GLP-1 agonist? Which one to
Because
start?
I was addressing cardiovascular. I'll tell you, I initiated SGLT2 inhibitor first for the first 2 weeks, monitoring her, because she was having, when she came to me, she was having shortness of breath. So I was not really sure if her diastolic function is affecting her, and she was having CKD. I wanted to protect her because the plan is to start her on GLP-1 agonist after that. So I wanted to give her a protection with a SGLT2 inhibitor.
Excellent. Thank you. Another question, Dr. Anada, for you to comment on prescribing both statin and fenofibrate combination.
As we know, like fibrate are excreted usually in the kidney, and there is a reversible or increase in the creatinine. Although maybe early fibrate drug was appeared to be associated with high risk of rhabdomyolysis, but current evidence suggests that fenofibrate does not interfere with the statin metabolism and has lower risk of myopathy and can be safe used in the combination. So this is what with the recent update. So most the contraindication is if patient have gallbladder disease or and sure you should stop it with progression of CKD.
Excellent. Thank you so much, Dr. Dr. Faisal, there is a question in regards to actually two questions regards why sometimes it is triglycerides is drop or there is no drop with the IV insulin. For example, in your case, it took 20 days IV insulin.
Yeah, in our case, actually, mostly patient has a genetic component, mostly has a familial hypertriglyceridemia with such high levels, and is not even though he's a diabetic and is a very mild diabetic. Patients with severe hypertriglyceridemia and patients with a severe familial component will take time to come down. And also what we saw that in some patients, the diet, what we prescribe, actually the fat-free diet, less than 5% fat is very efficacious in reducing it, but sometimes it doesn't work out for the patients. And also in familial cases, we see the resistant takes time for the insulin to reduce but the same patient, what we saw that with plasmapheresis, it came down very fast. So especially the younger age familial hypertriglyceridemia with genetic component it takes time for them, and IV insulin may not be as efficacious as plasmapheresis to lower down the triglyceride. But in fact, even though that the outcome doesn't change, even it takes time to bring down but IV insulin definitely helped him to come out of, like, to prevent him from the further damage to the pancreas.
Okay, excellent. I think we have only time for another one question. So, Dr. Asma, there is two questions actually commenting in finerenone. When would you consider adding finerenone?
Okay, so finerenone, it's available in our formulary. Usually we're starting finerenone after starting SGLT2 inhibitor. And so that's why I didn't start it from the beginning for the patients. And maybe I need to mention here albumin creatinine ratio was really go significantly down with the SGLT2 inhibitor. And I didn't need to really give her. It was almost reaching normal, giving her the SGLT2 inhibitor. I mean, and the patients who are not, improving, I would add finerenone. But at that time, I would be very cautious also because I need to change also other medication for the couple of risks like hyperkalemia risk and dehydration risk. Couple of things should be done on her cardiac and hypertensive medication.
Thank you so much. We exceeded the time for Q&A. I will appreciate if you can go through the Q&A questions and answer them in the Q&A section. Thank you so much, Dr. Anada. Thank you, Dr. Faisal. Thank you, Dr. Asma. It was a pleasure having you, and hopefully we can have you on a future meeting as well. Now we will move to the industrial talk and sponsored by Servier. And the title will be Gliclazide MR, Effectiveness and Safety in Real-World Setting. And our speaker is Dr. Vikram Hundia, who is a consultant physician in diabetes and endocrinology from Al-Zahra Hospital, Dubai. Welcome, Dr. Vikram, and you can share your presentation. Please unmute yourself, Dr. Vikram.
All right, sorry. Yeah. So I hope you can see my slides now.
Yes, we do. Thank you.
All right, thank you. So thank you, Dr. Raya, and thank you to the organizers and sponsors for giving me the opportunity to talk. I know that I've got only 15 minutes, so I'll crack on with my talk. The title of my talk is Gliclazide MR, Effectiveness and Safety in Real World Settings. I'm aware that, we've got these newer agents, and I'm quite a fan of them, like SGLT2 inhibitors and GLP-1 analogs. But I still believe that medicines like gliclazide have a role in treating our patients with diabetes, because as many of you would, I'm also having issues sometimes with, using these newer agents for patients who can't really afford it, or where there is difficulties in getting insurance approvals, in spite of giving all sorts of justifications to, get them approved. So I'll start my talk with this in mind. I don't know, my slide doesn't seem to be moving. Yeah, this is my disclosures. So I'll start by talking effectiveness of gliclazide, and this is in regards to the real-world study comparing gliclazide SR with sitagliptin. So the aim of the study was to compare the effectiveness and safety of gliclazide MR to sitagliptin as second-line therapy in patients with type 2 diabetes in real-world settings. And the primary outcome of the study was time to HbA1c level of less than 7%, while the secondary outcomes included HbA1c level of less than 6.5%, time it took to get the HbA1c levels below 6.5%, and time to reduction in HbA1c of more than 1% from baseline. And it also looked at treatment duration, which was measured both by durability and persistence. And it looked at the hypoglycemia event rates as well. So this was a study design where at index date, new users of gliclazide MR and sitagliptin were studied. And there was an observation period of 9 years, which ended in October of 2010. And the main inclusion criteria of this study was patients with type 2 diabetes who were over 18 years of age. And their first-line treatment was metformin, and they had HbA1c of more than 7% in the 6 months before the index date. So at the baseline period, the HbA1c had to be more than 7%. And on the right-hand side are the main exclusion criteria. These were the baseline characteristics. So you'll see that the mean HbA1c in both the groups was around 8.5%. In both the groups, patients were in the obese, BMI around 31, and the life duration was about 4.5 years. And here are the list of comorbidities and the medication that these patients were, and they are fairly equally matched. So if we look at the primary outcome, which was time to achieve HbA1c of less than 7%, then what we see is that the patients who were on gliclazide MR, there was a rapid separation of curve in favor of gliclazide, starting approximately at 3 months. So if you look at this red line here on the graph, that is for gliclazide, and the pink line is for patients who are on sitagliptin. So clearly, more patients early on were likely to reach the target or HbA1c of less than 7% with gliclazide SR versus sitagliptin. And if you look at the secondary outcome, which is time to achieve HbA1c of less than or equal to 6.5%, then once again, what you see is a very rapid separation of curves in favor in favor of gliclazide MR compared to sitagliptin, and 51% more likely to reach targets of HbA1c less than 6.5% with gliclazide MR compared to sitagliptin. And if we look at the durability and persistence, once again, you'll see that gliclazide MR has got similar durability and persistence compared to sitagliptin. And if you look at the hypoglycemia event rates, then you'll see that the event rates in patients who are on gliclazide is low and is not significantly different. So in summary, if you look at the effectiveness of sitagliptin and compare it with gliclazide MR, what you will see is that gliclazide MR is more effective in glucose lowering than sitagliptin, with similar rates of hypoglycemia, durability, and persistence to treatment. And we have extensive experience in using sulfonylureas, and we are well aware of the risks and benefits of this molecule. So now I'll move on from the effectiveness to the safety of diamicron, and I'll talk a little bit about the Ramadan study, which was a real-world study assessing safety and effectiveness of gliclazide MR during fasting. And we are all aware that during fasting, we always have concerns with regards to hypoglycemia for our patients who are fasting. So this was a real-world observational study. It was an international study which looked at patients with type 2 diabetes who were receiving gliclazide MR during Ramadan fast. And there was a GCC sub-arm of the study, which was a sub-analysis to examine whether the positive results that we saw in the Ramadan study, which included all patients from different countries, whether the same results were relevant to the GCC region. If we look at the breakdown of the study population, you'll see that nearly 30% of the patients were from Middle East and 24% of the patients were from Indonesia and Malaysia, while 46% of the patients were from the Indian subcontinent, which included India, Bangladesh, and Pakistan. These were the key inclusion criteria. So the main ones were patients with type 2 diabetes who were over 18 years of age, with controlled or suboptimally controlled HbA1c, and they were treated with breakable gliclazide MR 60 milligrams for at least 90 days prior to the first visit, which is visit 0 or the inclusion visit. These are the exclusion criteria on the right. And basically, once the patients were included in the study, there was a pre-Ramadan period of 6 to 8 weeks. There was a Ramadan period of 4 to 5 weeks, and then the post-Ramadan period of 4 to 6 weeks. And the patients were given a diary at visit 0, and the diary was collected at visit 1. And the participants continued the usual type 2 diabetes treatment according to the usual practice and doctor's recommendation. And during Ramadan, physicians advised the patient to take gliclazide MR at iftar time. So these are the baseline characteristics. So the patients in both the groups, whether that be global or in the GCC region, were in the middle age, and their mean HbA1c was 7.5 in the global population, while it was 7.9, which was a bit higher in the GCC region. And if you look at the mean dose of gliclazide MR, again, the mean dose was significantly higher in patients who are in the GCC area compared to patients elsewhere. And if we also look at the dose groups, then you'll see that nearly 50% of the patients in the GCC region were on 120 milligrams of gliclazide daily. So in the GCC region, the patients were having higher HbA1c and greater BMI compared to rest of the study population, and they had higher mean dose of gliclazide MR in the GCC countries, as I've mentioned before. And this may be important, and I'll come back to that in my coming slides. And if you look at the other baseline characteristics, so if you look at the IDF-DAR risk category, which could fall in moderate to low risk, high risk, or very high risk, then you'll see that over 50% of the patients in the GCC countries were very high risk to high risk, IDF-DAR risk category, while only around 16% of the patients in the rest of the study population were in this very high to high risk category. And this may explain why there was a slightly higher rate of symptomatic hypoglycemia seen in the GCC country compared to the global study population. But if you look at the confirmed hypoglycemia, whether that was symptomatic or whether it was biochemically confirmed, you'll see that there was no greater risk of confirmed hypoglycemia in either population. While if you look at the severe hypoglycemic events, there was no difference between the two. If we look at the HbA1c and the body weight, then what you will see is that, that there was a significant reduction in HbA1c comparing to the pre-Ramadan period and comparing that to the post-Ramadan period. So there was an HbA1c reduction of about 0.3% in patients who had completed their fasting and their HbA1c was checked post-Ramadan. And if you also looked at the weight of the patient pre-Ramadan and post-Ramadan, what you will see is that there was a reduction of about 0.7 kg in weight in patients during the post-Ramadan period. So clearly there was an improvement in HbA1c and body weight, which was observed in the GCC countries. And if we summarize the results in the GCC countries, what we'll see is that there was a 4.3% symptomatic hypoglycemia in this population. There was a very low confirmed hypoglycemia rate, and there was no severe hypoglycemic events in this population. And if you look at the HbA1c reductions, as I mentioned before, there was a minus 0.3% reduction in the HbA1c, which is significant. And also there was a significant weight loss or weight reduction of nearly 0.7 kilograms in patients who were on diamicron in the post-Ramadan period. So what it also shows is that patients who were treated with diamicron had no significant or very low risk of symptomatic hypoglycemia, but no severe hypoglycemia, and there was a significant improvement in their HbA1c as well as their weight reduction. And this is what this particular slide says. Now, there's always concerns regarding cardiovascular safety of sulfonylureas, and there were concerns because first generation sulfonylureas, there were increased, there were concerns regarding increased cardiovascular events. But I mean, if you look at the gliclazide MR and if you look at the cardiovascular safety for gliclazide MR, this particular systemic review and meta-analysis, which included several different studies, looked at various different sulfonylureas, and it looked at these sulfonylureas in relation to all-cause mortality and cardiovascular related mortality. And what you will see is that patients who are on gliclazide had a significantly lower risk of all-cause mortality compared to other sulfonylureas. And similarly, if you look at the cardiovascular related mortality, you will see that patients who are on gliclazide had a lower risk of cardiovascular related mortality compared to the other sulfonylureas. And if we talk about the renal benefits, I'm sure you are aware of the ADVANCE trial, which was published in 2009. And ADVANCE trial basically had two arms. One arm was patients. One arm was a hypertension arm, and the other was a glucose arm. And the patients, patients who were in the ADVANCE trial, the ADVANCE on trial was a follow-up period of the ADVANCE trial, and it was called ADVANCE on trial. And there is now 10-year data of patients who were enrolled in ADVANCE and ADVANCE on trial. And what it showed was that there was a significant reduction in new onset of microalbuminuria of about 9%. There was a reduction of 21% in new or worsening nephropathy. And there was a reduction of macroalbuminuria, new onset macroalbuminuria by nearly 30% in patients who were on gliclazide. And similarly, there was a 65% reduction in patients who went on and had end-stage renal disease in patients who were treated with gliclazide. So clearly, what we see from the data from ADVANCE on trial is that gliclazide may confer renal benefits as well. So with this, I'd like to conclude by saying that gliclazide MR is an effective oral agent for treatment of type 2 diabetes with higher proportion of patients reaching HbA1c target of less than 7% and less than 6.5% compared to sitagliptin, which is another commonly used medication in treating our patients with type 2 diabetes. And if you look at the hypoglycemia event rates on gliclazide MR, they're not significantly higher compared to sitagliptin. And all-cause and cardiovascular related mortality is lowest all sulfonylurea in patients on gliclazide. And gliclazide MR in ADVANCE on trial had shown renal benefits as well. With this, I would like to thank you.
Thank you so much, Dr. Vikram. I would like just to, we have, I think, 2 questions. There is a question in regard if there is any dose adjustment is needed for CKD patients with the gliclazide.
Yeah, gliclazide is generally, fairly safe, but in patients who got, EGFR of less than 30, I would either avoid it or if you really need to use it, I would reduce the dose. I'd use the lowest possible dose, which you might be able to control the sugar, or I'd add another agent.
Excellent.
But the risk of hypoglycemia is more with the other second generation sulfonylurea like glimepiride, because the glimepiride is broken down into metabolites which themselves can cause hypoglycemia, and in renal failure they can build up in the blood. So compared to that, gliclazide may be a little bit more safer.
There is also another question in regard for patients who are already in a gliclazide and they are going to start them in GLP-1 agonist. What do you do with the gliclazide? Do you reduce the dose, stop it, or just educate the patient in case of symptoms of hypoglycemia to hold the gliclazide? What is your practice?
Yeah, it's a good question actually, because if you got a patient who is fairly well controlled, so for example, if they've got their HbA1c of 7.5% and you're adding a GLP-1 log, then there is, there's good likelihood that with GLP-1 alone, you might be able to, along with, metformin, etc., you might be able to control the diabetes. And to avoid hypoglycemia, I may consider withdrawing, gliclazide. But equally, if you got a patient who's got significantly higher HbA1c levels uncontrolled, then you may consider reducing the dose, maybe reducing it to half the dose and see what happens. You can always increase the dose if you need. But what I'm worried about is hypoglycemia, and I would rather avoid hypoglycemia if possible.
Excellent. Thank you so much, Dr. Vikram. Thanks for all our speakers. And we received lots of comments in the Q&A, thanking you, and thanks for answering the questions in the Q&A section. So for those who want the CME, it will be available after 4 weeks from the webinar. But you need to fill the evaluation that will be sent to your registered email. If you would like to review this webinar again, it will be available on the on-demand and ADS Institute website, as well as ADS YouTube channel. For any future events you would like to know about or any upcoming webinars, just visit the society website where you will see the announcement for the upcoming webinar. Again, thank you so much for your attending, and hope we can see you in the upcoming Young Leader Forum webinars. Thank you so much.